To respect everyone's time, I think we are a few minutes over already. I'll be talking about insulin stacking. How much risk is it with advanced CKD or ESKD? The learning objectives to review the pathophysiological mechanisms leading to insulin stacking, to enumerate recommended medication adjustments and changes based on glomerular filtration rates based on CKD stages, and lastly, to discuss the clinical implications and management of insulin stacking in advanced CKD and ESKD. I have nothing to disclose. By way of introduction, I'll be talking about some cases that I've actually experienced that actually made me review this again. I've always thought that with advanced CKD, we should be very careful with insulin therapy. But my experience with recommendations to patients through their endocrinologist made me to look more into this, whether this is really a risk. Because I was getting the impression that having endocrinologists don't really think this is a risk. So the first case is that of a 8-year-old. Actually, this patient was one of those I got in the outpatients after I was initiated on dialysis. His diabetes was complicated by retinopathy, neuropathy. He had BKA, and then I saw him during his outpatient dialysis round, and he was still on Lantus and Novolog. During that round, I remember bringing it up that he needs to schedule an appointment with his endocrinologist for them to look more into adjusting his regimen, especially the one about Lantus. Unfortunately, before my next round, I just got a call that he didn't show up for dialysis, and they called around. They actually had to call the police to go look at his house, and they found him dead. I felt guilty that I thought maybe he might have been at risk for hypoglycemia. So I questioned, would that have been the reason why this man died? But there's no way we could prove that. The second case is that of 85-year-old lady with hypertension, diabetes, Lantus and Glycoside and Jardiance. With CKD4, I saw this lady routinely, and during this particular clinic encounter, told me that she was hospitalized for symptomatic hypoglycemia, and she spent a couple of weeks in the hospital, outside hospital really, and then she was so deconditioned by the time she was discharged. She even had to go to rehab, and but by the time she showed up in the clinic, she was still on Lantus and Glycoside. So that also created some impression in me. I'll share more after I'm done talking about what I have to say regarding this. The third case is that of 38-year-old with type 1 diabetes, complicated by severe blindness from retinopathy, also neuropathy. This patient had been on Humalog and Lantus, and have been seeing this patient also in the outpatient dialysis unit, and multiple times we tried to get this patient to get a PCP or the primary endocrinologist to adjust their diabetes regimen, but because they were out of network, it was difficult till we tried referring them to our own PCP in here. They had some trouble. Then she was hospitalized after new seizures, and the blood glucose, they said it was in the 60s. Our presentation this patient spent multiple weeks and months in the hospital and was eventually discharged to rehab. And I think the last thing I heard about her that actually she passed away at rehab. Now weighing the evidence, I find this very useful. A number of you that probably might have maybe witnessed me talking about grounds. I usually refer to this. So this pyramid of increasing evidence. The evidence, I know Dr. Atamizoda will make us sort of look more at the apex of the pyramid, but without those ones at the lower part as well, we probably might not have enough to sort of review them up there as well. But in terms of the strength of the evidence, randomized control trial, we know that well, systematic review, meta-analysis will actually give you good strength of evidence for you to weigh the information, the evidence you're actually getting. Now talking about the glucose homeostasis in the body. We all know that the insulin is secreted by pancreatic B cells, and I had to sort of slow down to see this, that actually insulin is secreted continuously. In medical school, of course, we were told about that, but it's continuous, but it's in pulses. And this represents the basal insulin output. And this is also in between meals and throughout the night, even when we sleep. Now this is augmented when we eat by short surges of insulin response to food. And the postprandial insulin level peaks around 1 hour following a meal. And insulin concentration gradually returns to baseline level within 4 hours. Just to remind us the structures of insulin, how we make use of C-peptide being part of proinsulin, and when it's secreted, we could tell between exogenous and endogenous by us sort of looking out for C-peptide. Our transplant colleagues use that a lot when they're talking about transplanted pancreas and trying to see how functional that is. Now, how is insulin secreted? The form of energy comes as glucose, enters the cell through GLUT receptor, and then through Krebs cycle, ATP is produced, and this leads to potassium effluxing from the cell, and this eventually leads to depolarization, and calcium enters the cell, and this actually gets the pancreatic big cell to secrete insulin, and exocytose out of the cell. Now, insulin stacking. In essence, what it means is that there's excessive accumulation of insulin in the circulation. But typically, the endocrinologists will actually refer to this when they're talking about giving short-acting insulins, generally to correct hyperglycemia, before actually the prandial insulin that has been given actually kicks into full effect. Other people have also described it when, especially during clamp study, glucose clamp study, when they're infusing insulin and glucose, and when you're using the level of glucose to sort of tell the effect of the insulin that is still in circulation about what is actually happening in the future based on the doses that have been given before. Some people have actually described this as being bolus and blood. X et al. Actually did some studies, and they were able to substantiate a number of things regarding rapid-acting insulin, especially when you're giving it, you're expecting it to work within 1 to 2 hours. And that actually might still be in the system, but by the time you check your blood glucose around that time, you're going to still think that probably patients still hyperglycemic, and if you correct at that stage, with the insulin still in circulation, gets stacked, and actually the overall effect you get from that will be that. And you can imagine that if you give long-acting insulin, actually, if this is human basal insulin, you could see that the effect is more pronounced if you actually correct from here. So the difference actually, the desired effect would be for it to be there, but the overall effect you're going to get will be the accumulated schema in purple here. And this is actually another study done through glucose clamp studies, in which case you're aiming to have your glucose concentration to be between 90 and 100, and you're trying to sort of study the effect of the insulin by actually monitoring the glucose as you're giving the insulin. So you're trying to sort of get a level, as in your goal is to have glucose between 90 and 100. So if it falls below that, you're thinking that the insulin action is actually working more. Then you give more just to keep that concentration within 90 and 100. And what we can tell in terms of the half-life of insulin here is that, yes, initially, you're going to see much of the effects sort of kicking in more than the glucose you're getting. And over time, you're going to see that actually a lot of the glucose are actually now leaving the circulation because of the stacking of the insulin that's been piling up over time. And if we have to use this to study how insulin actually works, if we're thinking of the pharmacokinetics, we'll be thinking about absorption, distribution, metabolism, and elimination. One would expect that probably towards the end of the pharmacokinetics pathway here, that probably the organs that are getting rid of insulin, liver and kidney, will probably be the one responsible for clearing insulin at this stage. But based on a number of studies, this has been actually described as being flip-flop kinetics, because the bulk of the effect you're seeing at that time actually is not because of the elimination by the organs, but by distribution into organs like the muscles and into the livers, rather than actually being eliminated from the body directly. Looking at the half-life of insulin generally, based on this study by Hannes and his colleagues, injecting insulin, it takes at least 4 to 5 half-lives for you to actually achieve your desired effects. If probably you're talking about long-acting insulin that you have to give once a day, if you're aiming to have a steady state of 10 units, the first day you give it, you're probably, if you're talking about the half-life, you're probably getting half of that at the steady state at 5. So the second day, as in stacking on that, you probably end up at around 7.5 and all the way down. So it takes about 5 to 6 days before you could actually achieve your 10 unit steady state. And the same actually was used to actually explain all these multiple types of insulin, like the rapid acting that you expect the half-life to be about 1.3 hours, and the basal insulin, some will have 6 hours half-life, some 12 and a half, like degludec, that will be about 24 hours. If you're following the mealtime dosing, this is the pattern you see. But if you miss the dose, this is what you're likely to see. But if you accidentally give that over the 1.3 hours, the pattern you're going to see in terms of its effect, will be much of stacking in here. So if you're trying to sort of catch up to actually do strict glucose control with short acting, you might actually end up sort of precipitating hypoglycemia. The same also goes for applying this to the basal insulins, in which case these are the kind of patterns you're going to get if you miss the dose or if you're giving double dose. So regarding the elimination now, the physiologic endogenous insulin secretions is usually at the rate of 0.5 to 1 unit per hour. Now with mealtime, the secretion actually goes 3 to 10 times, and this goes over 4 hours, and then it returns to the basal rate. Now, the basic pulsatile insulin secretion is usually mediated by blood glucose, and the first rise will be within 3 to 5 minutes, and followed by slower and extended phase of about 1 to 2 hours. Now, with things not going right, for example, in obesity, the basal and postprandial secretion rates, they're maintained in up to 5 to 6 rates higher than what is expected, and usually they do not return to basal rate. In type 1 diabetes, which we know is more about insulin deficiency, right? So it's tough to actually say that there's actually a significant insulin secretion pattern in there, because that's the disease activities. In type 2, there's usually blunted glucose mediated insulin secretion of about 70% of normal. Now, in terms of the biphasic pulsatile insulin secretions mediated by insulin, the first phase actually is lost in both those who even have pre-diabetes and those who have type 2 diabetes mellitus. Now, in terms of the metabolisms, yes, kidney and a number of other organs in the body, they play good roles in this. But this is through multiple and complex interactions. During the fed states, 20% of all glucose removed from circulation is actually by the kidney. During prolonged fasting states, 20 to 25% of blood glucose is actually through gluconeogenesis by the kidney.
Do you know where that data comes from?
From us?
I'm sorry to interrupt.
It's all right.
So this last statement was from a study done about 40 years ago where they put people into a fasting state for 4 to 6 weeks. Okay. After 4 to 6 weeks of feeding them water, they could show that about 25% of the sugar, the glucose in the body was through gluconeogenesis. I don't.
You don't agree.
Sorry to interrupt you.
It's all right. It's all right.
How would we have to compensate the patient for 4 weeks of fasting?
This was treatment for morbid obesity. Maybe it was 50 or 60 years ago.
Wow.
But it was for people who, now, morbid obesity included people 220 to 250 pounds.
Yeah.
So this was treatment for morbid obesity, was prolonged inpatient fasting to make certain.
But you know, the increase in the strikes, there are studies that did after 2 weeks, they start to get hypothermia, they go into arrhythmia. We cannot go for 4 to 6 weeks of full fasting. They probably were feeding them something.
There are people in India who have religious fasting for 4 weeks.
Oh, yeah, no, same with
They
the,
know, they just drink water.
the IRA prisoners in May's prison in the early 80s. Bobby Sands starved himself for 68 days.
60 days, yeah.
This is before IRB.
This is clinical treatment. This is not a research protocol.
That is how you treat obesity.
Circa 2010, there was a study at UCLA that patients were given 700 calories a day in a meal. And they showed decrease in body weight based on that. Made waves in the endocrine world. And I think that to the point where my PhD PI had to make a TV statement about it. Like, yeah, we know it works. But just that it's really hard to physically do, right? So people were not, water only, just low calorie diet. So, and the same thing in the animal world, but it's cruel and there are better ways to do it. So bottom line, I think prolonged fasting is very safe in some patients.
Now regarding insulin that produced or cleared endogenously, about half of that is actually by the liver. The remaining half that is going into circulation get presented to the filtering organ, the kidney, and about 60 to 65% of that actually goes through the glomerulus, and they are actually taken into the proximal tubes. Now, the remaining 35% that goes through the postglomerular peritubal vessels actually eventually end up within the proximal tubules as well. And the gradation, actually, the metabolism happens within the proximal tubule, the powerhouse of the kidney. Now, regarding exogenous insulin clearance, because there is no first pass effect, yes, so this, we think kidney actually does a lot of the metabolism of exogenous insulin, about 80%. Now, at the end of the day, if we consider the kidney, based on the study by Galindo and his, I think it's in Emory. So the systemic insulin clearance is about 30 to 80% by the kidney, especially if it's exogenous. And about 1% of insulin, of urine, actually is that of insulin. Now in disease, in early and advanced chronic kidney disease. Now, because of the uremic milieu, yes, the muscle and also the rest of the other tissues are actually impaired by the way they actually interact with insulin, as in make use of insulin and also getting glucose. So there is also the diseased kidney, as you can imagine, will not be able to do its job well. Also, because we know CKD is that mild inflammatory states that also affect how these mechanisms actually work. Now, the counter-regulatory hormones like cortisol and growth hormone, they actually go more into action when uremia actually is the one dominating the way here. Now, in early CKD, there's actually more of predisposition to postprandial hyperglycemia, mostly due to osmotic diuresis and the muscle resistance to insulin. Now, increased insulin resistance, development of acquired defects in insulin receptor signaling pathway from vitamin D. Some studies have talked about that. Obesity, metabolic acidosis, accumulation of uremic toxins all contribute into the pathophysiology here. And the factors that have been proposed are, yes, there's prolonged half-life of endogenous or even exogenous insulin. There's lessened insulin resistance resulting from removal of uremic toxins, especially if they're on dialysis, meaning you're making the system to be more sensitive to this insulin that is around once you remove uremia during dialysis. Gluconeogenesis, being impaired by the uremic milieu is reduced, so the chances of people getting more prone to hypoglycemia actually is commoner as the CKD worsens. And as we know that their appetite gets low, so there's nothing coming in, so they're still also more predisposed to hypoglycemia. Now, this will be in early and early, early going towards advanced CKD. And actually, as CKD progresses with all the factors we've talked about, Rahul and his colleague were able to actually depict that there is actually something called burnout diabetes. Actually, yesterday, I still had a patient, CKD5, we're still watching on whether they should be initiated on dialysis or not. They said, oh, my diabetes is better controlled now. I was trying to make it out. He said, that's good, right? Saying, I think it's because CKD is getting worse, right? But it took me a while to be able to convince them. But this happens in about 15 to 30% of advanced CKD. So with burnout diabetes, now, if we now give insulin that is long-acting, as you can imagine, that will lead more to hypoglycemia happening in such patients. This were the things, this picture is just depicting the things I've been talking about. So in early CKD, yes, hyperglycemia is what dominates, but as CKD advances, hypoglycemia is actually what dominates. And this is a summary of what we see generally. Glucose and insulin metabolism, yes, there's decreased gluconeogenesis, there's impaired insulin clearance and degradation, there's variability of exposure to hypoglycemic effects, nutritional deprivation, glucose concentration of the dialysate, insulin resistant, and beta cell being impaired in secretion. To enumerate the medication changes. As we know, KDIGO advises us a lot about things like this. And actually, with KDIGO, there's always a consensus report between American Diabetes Association and KDIGO. Each time KDIGO is reviewed. This is just to remind us about the staging in which we put G1, G2, G3, AB, especially when it comes to the hallmark of diabetes in terms of how much albuminuria, glomerular proteinuria we have. For the medications we have, we can sort of take from this, as in red is probably bad. So insulin will come with that high hypoglycemic risk. And so also sulfonylureas, right? And if you still continue, yes, they may also get weight gain as well. And we know the number of things that will still come with that. But SGLT2 inhibitors, yes, you could still do well with them if you start them, especially before the actually GFR goes below 20. But the advice is that even if they are progressing, yes, you could continue with that. And actually, you could advise to leave that. I've had to actually advise a number of my patients for them to consider being switched over to that instead of them staying on insulin. If I know this probably going to have some trouble getting to the PCP or endocrinologist, I might just prescribe that and ask them to stop insulin while they're waiting to reconcile with their primary PCP and endocrinologist. Now, as still part of the consensus report regarding advanced CKDs, especially when GFR is less than 45. As we know, metformin is contraindicated, usually when it's less than 30. SGLT2 is great. All the other fluoxetines, actually this fluoxetine, I'm not sure it's actually available in the market yet. use is not recommended. Now for the GLP-1 receptor agonists, they are really coming into helping us prolong kidney function now. This use of exenatide actually is contraindicated. And this as well, glyburide, yes, we know about that so well, use not recommended. Glipizide, glimepiride could still be given to patients. And in terms of alpha glucosidase inhibitors, accables, sorry, I guess I could make that easier with that, really. Now, accables actually use not recommended as things are getting worse with kidney function. Now to discuss the clinical implications. Now, sorry about that. These are the types of insulin available in the market for now. There's the Detema 100, there's Glargine 100, and there's Glargine 300, and there's the Gludec. In terms of their half-life, is showed accordingly here, 4 hours for MPH, and for the Gludec, it's going to be 5 hours. So these are given based on their half-life. And just like we talked about, 4 to 5 sort of doses you get into the steady states. Now, in terms of other things that complicates CKD in terms of metabolism of insulin and also managing glucose, especially if patients are on dialysis. This actually took me through, history lane, really. Previously, they used to use dialysis with high glucose concentration up to about 1600 milligram per DL, but we saw that patients developed a lot of hypoglycemia there. And then with us getting better in ultrafiltration, and now people switching over to glucose-free dialysis, then we got that transition to patients getting hypoglycemic. Now the current standard concentration in our dialysis mostly are actually usually within 100 and 200 milligram per DL. PD solutions, we know 1.5, 2.5, 4.25 will have insulin. So actually people getting hypoglycemic is rare with PD. But what comes in exchange for that? Weight gain and also higher insulin requirement. Now, also reduced plasma insulin removal during dialysis, and also with you clearing out uremic toxins, that has some effects intermittently on how the pancreatic cells are actually secreting, and that also affects what you see with the glucose within the bloodstream of the patients and the effect you actually get with insulin interacting with that. So essentially, patients with advanced CKD, ESKD, they are more prone to hypoglycemia. Now, the wide excursions they could get actually have been sort of proposed to be responsible for a number of vasculopathies that actually happens because of reduced oxygen radical being more in them due to advanced glycation end products being produced in them, and then leading to endothelial cells injury, podocyte injuries, mesangial cells, and all this are pro-inflammatory. And actually, a number of tests have been able to support this based on a number of tests that have been done, studies that have been done. Now, which level can we say is actually safe for our patients, especially if you have to say we are following hemoglobin A1C. Just like we said, the uremic milieu changes so many things. You even find it difficult to be able to follow A1C to be the true picture of what you're getting in your patients. But despite all the challenges there as well, we still don't have any other way to sort of measure how things go. So with the challenges, we still go by A1C. And usually what they describe mostly is that based on the number of studies, the hazard ratio usually depicts a sort of U-shaped effect, as in being too low is trouble, being too high is trouble. So where is the safest range? Some people will say maybe less than between 6.5 and 8.5. Some will say between 8 and between 6 and 8. But a number of studies actually Galindo reviewed a number of cases, and he still came up with something being safe between 6.5 and 8.5. If you're a lot less than that, yes, you could see that the hazard ratio may be a little bit worse. Also, if things are higher. Actually, there was a patient of mine that was admitted recently, as in they checked A1C based to each other. One of them came back as 5 point something. The other one came back as 9 point something, just to tell you within days what uremic toxins or uremic milieu may have on you assessing A1C. Now, regarding a study, the patient population for this study actually depicts a number of the patients we have with diabetes, with ESKD or advanced CKD. So we actually represent that fairly well. Now, what was the trouble that were found when these patients were hospitalized with DKA? So these are patients on dialysis. As we know, if we're thinking of DKA, especially in non-diabetics, volume contraction is usually what we see, but our patients are different, all right? So volume contraction is usually not the trouble with our patients. But now if we go in being very strict with controlling blood glucose in them, the kind of the results we're seeing in some of the studies out here is actually what tells us that quite a number of things may be a danger in being very strict with a management. So glucose, for example, those on ESRD based on this study, they came in, it was in the 800s for those on ESRD, and those not on dialysis, 472. Yes, both of them came in hyponatremic, meaning probably a lot of fluid on board, but that probably may be due to fluid contraction or a mixture of both. This was more in ESRD patients. Now, in terms of how they were managed in the hospital, as in trying to get their glucose fairly controlled, this was the outcome that was found during the hospitalization. Yes, so those that actually were found to be hypoglycemic were more of those with on dialysis ESKD patient compared to the non-dialysis patients. And in terms of volume overload, them ending up on mechanical ventilation as well, it was also based on, it was also more for those who have ESKD. And in terms of the overall outcome, I think talked about that. Sepsis, as we know, uremic milieu predisposes patients generally to severe sepsis. So the p-value based on this study was significant, and so it veered more towards those who are on ESRD. So also the 30-day mortality and also length of stay, and also 1-year mortality in our patients. So hypoglycemia, if you go too strict with the management when they're coming in, the studies at least we have right now, Galindo has done multiple reviews on this, and actually, so the advice is that we should veer away from being too strict in our patients. Also, this is another one, but this looked more into adjusted dialysis complication scores in them, and as we could see, actually the summary of this study is that if patients had hypoglycemic episode before they got started on dialysis, and when they get started on dialysis, you don't do much about that, the chances of them having multiple episodes of hypoglycemia is there, and actually that may worsen their morbidity mortality of being on dialysis. We know that is already cut short to 3 to 5 years. So now you could be thinking about, months and a lot less than expectation for that. Now, this is another study regarding this, as in terms of patient being on dialysis, if they continue to have multiple hypoglycemic episodes, yes, this actually, sorry about that. This leads to more hypoglycemic episodes down the line, and actually this also worsens their overall mortality risk as well. Now, I'm sorry, this is a very, I think this is a study from Israel, about 1,500 patients admitted, and now they found about 56 of them being hypoglycemics, and they were trying to sort of delineate what was responsible for their hypoglycemia. Apart from sepsis, medication-induced hypoglycemia was found in those who have ESKD that were hypoglycemic on hospitalization. Now, so yes, the consensus advice is that yes, we should be holistic, as in yes, advise patients about their lifestyle changes and a number of other things. If you see that they're really still suffering from maybe non-burnout diabetes, but by the time they're burned out, I think insulin actually should be avoided. And the takeaways for patients from KDIGO clinical practice that regarding A1C, yes, it's still difficult for us to rely on it based on the number of challenges, but it's still the only one we have at this time. Some actually authors have they've looked into continuous glucose monitoring, like using DESCOM, especially in advanced CKD, or maybe those on dialysis. Even those who don't have complications, we know what they go through before insurance could actually approve that for them. So that's going to be a lot of challenges for our patients. But at this time, there's still no strong evidence to support that. Galindo recently reviewed a number of cases in which continuous glucose monitoring was actually used. And at the end of the day, his summary was that we still need a lot of work to do on this before we can actually bring this to the limelight. Now to my patients. So I still don't have the evidence that probably hypoglycemic episode was the one responsible for the patient that was found dead. But our patients generally with ESKD, they're prone to sudden death. But it was just that because I thought about it and something happened before the next time I was going to see this patient. Yes, it's still at the back of my mind. Time I see a patient, it makes me to still want to go at a good length to get that change. Now the second patient, I recommended to their endocrinologist to adjust their insulin, the diabetes regimen, and that's Lantus at this stage, 85-year-old getting hospitalized multiple times with hypoglycemia, getting the condition. I've told the patient to try and seek, and if they're not hearing back from them, they should probably stop that. Now for the 38-year-old, yes, I think my experience with that patient still reminds me that yes, despite some of the pushback I get from endocrinologists sometimes, that I should still keep at it. Actually, one of the endocrinologists here said, yes, we should do a study to prove this. I said, okay, insulin stacking, I thought I learned about this when I was in internal medicine. So, but I guess most of diabetes patients are seen by maybe physician assistants. I'm not sure whether endocrinologists, colleagues actually maybe they are so involved with this as well. So I think with our patient, I think we should play a more active role in being strong with our recommendations regarding insulin therapy. This the end of what I have to say based on my experience with insulin stacking and advanced CKD. Thank you.
I just want to add the concept of hypoglycemic unawareness, especially in ESKD patients with that neuropathy. And then once hypoglycemic, they may not have the typical symptoms because of autonomic dysfunction, like medication, sweating. They might not know that they are having hypoglycemic episode. And once one episode of hypoglycemia makes it harder to have awareness of the second and third episode, and the reset point takes few months to get back to normal. So I think that is a unique challenge in our patients with ESRD. I don't know if we should just do it instead of, you are right, because I have reached out to endocrine a couple of times, and oftentimes it's a physician assistant. And one of the physician assistant at least that work is like really very dismissive. I have had to contact the attending on several occasions.
Yes.
Thanks for that.
So I second that. And I want to thank you so much for bringing this important topic to limelight today and discussing it. I think this, this problem has actually most people who manage CKD patients in clinic and maybe in outpatient dialysis. I too have had a share of experiences that I can't, quite understand. There's a disconnect between the way we look at hypoglycemia as nephrologists and the way the endocrinology service looks at it. In my case, these are the lung transplant patients who had hyperglycemia post-transplant, right, on high-dose steroids. They're still on insulin, getting hypoglycemic with hemoglobin A1C of 5.4. And I have a hard time, and now they have CKD4, of course. And now I have a hard time taking them off insulin because there's so much resistance, and it's coming. We have everyone looped in the same loop in the same chat with endocrine, and there's some literature, at least in transplant, is circulating for better outcomes with higher glucose control. Yeah, and then of course I get studies 10,000, 6,000 people, and say people dying more with higher glucose control. That's from 2010. But what do you think can be done as a system, in the system level? I feel like, I feel like its patients would benefit if we approach it more systemically.
Right, yeah, actually, if I have to base off my experience with one of the endocrinologists, he said, yes, you feel so strongly about this. This is not the first time I'm going to be hearing from your team about that. Can we do a study about this locally?
Or just quality improvement.
Yeah,
Quality improvement project.
yeah. So I think it may be something for us to maybe consider, right?
Yeah.
And yeah, so maybe with that, maybe we may be able to convince them to think about this more strongly, I think.
We can have more staff on endocrinologists if appointments like a year out.
Oh.
I had a question.
For us to follow while they are waiting to see you.
I think we can come up with a protocol.
Sorry.
I think we can provide up, I think it's very, very doable.
I had a question.
Yes, sir.
Degludec.
Yes.
So I think there was a study showing Degludec combined Lantus episodes of hypoglycemia were less with Degludec. Do you know the mechanism? Like both are 24 hours almost. And
Right.
is there any data on CKD patient if it's lower episode of hypoglycemia on Degludec compared to Lantus?
Right, so the study that actually talked about this said this actually simulates a lot about how her body actually gets all the profiles done after, the bigger secretion that because it's so long acting, actually, I think there's Degludec 100, there's Degludec 200, there's Degludec 300, and that's the longer acting ones up to like 72 hours are just going to be producing little by little by little by little, as in the active part out of it actually is just being released little by little. That is not active enough to sort of make them hypoglycemic.
Did they study that in CKD patient if that's beneficial?
No.
Because then we can just say
No.
use Degludec in CKD.
Yeah, no, that study actually didn't include